Welcome to Journal of Cardiac Failure's YouTube channel.
Heart function, not failure.
Heart success.
Mentorship.
Unwept matters.
We care.
We hope you enjoy the episode.
Hello and welcome to the JCF YouTube channel. I'm Rob Mentz, the editor, and I'm so glad you joined us today as we talk about a really important topic around COVID-19 vaccination and transplant eligibility. Without further ado, I'll hand it over to Quentin, one of our fellow editors, to do some introductions and then jump right into our moderated discussion.
Thanks so much, Rob. Today, I have the honor of welcoming our two guests and moderating what I'm sure will be a wonderful discussion. First, I'd like to welcome Dr. Arthur Caplan, the doctors William F. and Virginia Connolly Mitty, professor and founding head of the Division of Medical Ethics at NYU School of Medicine in New York City. Dr. Caplan is the author or editor of 35 books and over 850 papers in peer-reviewed journals. His most recent books are titled Vaccination Ethics and Policy with Jason Schwartz and Getting to Good, Research Integrity in Biomedicine with Barbara Redmond. Welcome, Art.
Thank you for having me.
Second, Brendan Perrin is Director of Transplant Ethics and Policy Research and Assistant Professor of Bioethics in the Division of Medical Ethics with joint appointment in surgery at NYU Grossman School of Medicine. He is Editor-in-Chief of the Health Law Journal for the New York State Bar Association, a fellow for the Center for Genetics and Society, and a member of the Tri-Sci Embryonic Stem Cell Research Oversight Committee. He has published academic articles in peer-reviewed journals spanning law, medicine, science, sports, and ethics. Welcome, Brendan.
Pleasure to be here.
Awesome. So let's jump right in. So, this is a really important discussion, especially in the setting of recent news coming out of Boston in which a patient was denied consideration for heart transplantation because he was not vaccinated. So taking a step back, why is transplant more broadly a special circumstance when considering provision of care from an ethical perspective? Why don't we start with you, Art?
Well, transplantation has proven to be, for me, one of the most interesting areas for looking at ethical problems and dilemmas. We get organs by relying on public trust and altruism. We volunteer to give our organs when we die. Some of us donate a kidney when we're alive, but it basically is a system that says you can't buy organs and we can't take your organ. We need your voluntary altruistic consent. There's not a lot of areas of healthcare that operate with that foundation. It also means the public is involved in a way that just isn't true of many other parts of medicine. They supply the practical treatment that everybody else then awaits. On the other end, distribution, sadly, there aren't enough organs to transplant. Since I've been looking at transplant for many, many decades, it's always been shortage. You have to ration. Issues then come up about, so who gets a scarce life-saving resource? This isn't the same as arguing about who gets a beach chair at a resort. We're talking about some people are going to die every day because they don't get an organ. So issues around eligibility, accountability, transparency, what's the principle to follow in allocating a scarce resource, core questions of ethics are right there at the forefront.
I think the only thing I'll add is that, just to frame again, is that we want to provide optimal care for one's condition, right? But because of what Art said, that we have to ration, we also have to consider who will get the most benefit from these organs.
Absolutely. So that is a great context to think about, organs more broadly and specifically in transplantation. And so let's talk a little bit about, vaccination more specifically. So in general, we know that mandates can feel overly onerous for some patients who value their personal autonomy and their ability to decide for themselves what treatments they may take. From the healthcare side, obviously, we often have to think about how to do the most good, as you alluded to, Art, for the most amount of patients. So what is it about transplantation that makes a vaccine mandate specifically a requirement? What do you think about that, Brendan?
Well, I'll take a step back and say it could be a requirement. It's not necessarily, the case that it should be. But to the extent that it is, or places want to institute a requirement, it's because this notion of freedom to pursue your own version of what's the good life has to be constrained, right? There has to be a caveat, which is you can do what you want to the extent that it doesn't unreasonably interfere with other people, right? And the pandemic and the coronavirus is a perfect example where our liberties have to be constrained so that we protect society, right? And the vaccine has demonstrated that it is the most effective way to protect health, protect society. And when it comes to allocating organs, the best way to ensure that those organs will succeed in the person who gets them, along with other measures.
So I'll add that vaccination reduces transmission, admittedly less so for the Omicron variant, but a little bit. But it really protects the individual who's vaccinated against death, long-term serious hospitalization. It makes you less sick. If that presumption is then that it is helpful for you to live and survive an infection, and if, as we know, in transplant, it's not just installing a kidney or throwing a heart into somebody and everybody goes home. Post-transplant, you have a long, arduous recovery. You have to take immunosuppression, which tunes down your ability to fight off infection. And doctors are trying to balance the immunosuppression against making you so immunosuppressed that you can't fight off any infection. COVID is a kind of an infection. If it is true that you can build up some immunity that helps survival post-transplant, that becomes, as Brendan said, something to think about hard as to whether then you're going to say you have to do that if you're going to be a high priority or even eligible for a transplant.
Thank you so much. And I think this brings in sort of, that mention of taking immunosuppression brings in a broader thought. And I'd like to bring Rob and Anu in just for thoughts about, the fact that the vaccine potentially is just one component of things that are necessary for patients and that we expect of patients whenever they go through heart transplantation. There's also immunosuppression and physical therapy and all of the medicines that go along with it. How do you think vaccines fit into the broader necessity or requirements that are there for patients who undergo heart transplantation?
Yeah, maybe a couple quick comments, and then I'll hand it to Anu. So I think what our authors here in their recent piece in JCF so nicely laid out for the balance behind all of these elements, right? So this is not the only piece of the puzzle that we look at. We need to make sure they can take their immune suppression, like you noted, that they have ways to safely and effectively get back to clinic, that they're abstaining from other behavioral choices like smoking and alcohol and other drug use. And we really want to make sure that we're good stewards of the organ. I think their piece in JCF Ignite so nicely brings out all of these points in a way that is balanced, measured. And I'll be honest, it's changed how I talk about this with my patients in clinic who are considering vaccination pre-transplant and the conversations I have with them. But Anu, what would you add?
Thanks so much, Rob. This is such an unbelievably important discussion. Our group and many others have shown that if COVID-19 affects a patient with pre-existing heart failure, the outcomes are much worse compared to the general population who contracts COVID-19 and is hospitalized. And so what is that? What do we do? How do we piece all of this information together? And then, as you so nicely stated, we are stewards of this incredibly rare resource. So I think of it, and I think, Art, you already alluded to this, is that it's not just, oh, you're a candidate for transplant, you're being denied transplant. Many of you have heard, the God Committee on Netflix is a recent kind of thing that has come about. But it's really about, are you going to do well with this therapy? That's what it is for us, right? That's what we're trying to do a good job on understanding and selecting patients for. It's not so much a judgment, it's not so much a selection, but rather it's an understanding of which patient is going to be most likely to do really well with this therapy. And that's where this comes into play in such an important way that has already been discussed, is that we know that vaccination reduces your likelihood of death and hospitalizations and being incredibly ill. We know you're going to have to take immunosuppression. And so it's about putting all of these pieces of information together to allow for us to then say, okay, you have a higher probability of doing well based on the fact that you have been vaccinated, that you have done all these other things as well.
Thank you all so much. I think this is really important context to understand how the vaccine is just one important piece that's broader in the sense for, how can we best care for the patient that's in front of us. I'd love to kind of switch our lens a little bit and think about that from the patient perspective. Obviously, there are many reasons why patients might have vaccine hesitancy or might be hesitant to get vaccinations. From your perspectives, what are some ways or things that, academic centers or transplant centers can think about shifting that or helping patients kind of overcome that reluctance to vaccination?
I'm glad this came up because I think some of the conversation about competition and the unfortunate need to ration can sound almost punitive, right? And I think it's important that we, the medical establishment, healthcare, tries to help people, right? Enable people to be eligible, right? I think any good public health campaign has at least two components. One is like regulation, right? Policy, and the other is education, right? We can't just implement these mandates and say, well, that's the bar. You either meet the bar or you don't, right? I think we know that there are social structures that make people vaccine hesitant, right? And if we can help these individuals understand the consequences and provide them with support through education, through resources, through time to think about it, if they, just like we have, I think, an obligation in other realms of other aspects of transplant to try to make them eligible. We don't just say, oh, hey, well, you drank, so you don't get a liver, right? Instead, we say, okay, well, can we create an environment where you can demonstrate sobriety so that you can be eligible? Same with the vaccine. Can we create an environment where you understand the benefits of the vaccine, you overcome these fears, right? And you're willing to get it. So I think the support and the resources are a critical component. And I'll say that maybe in some circumstances, the mandate could occasionally create more difficulty for people to come around to that point than not having it, right? So we have to think about the outcomes.
Let me jump in with a comment from an entirely different arena, orthopedics. So people need hip, knee, shoulder replacement. For many orthopedic programs, it's true in New York City at the major orthopedic hospitals. If I need a knee or a hip, I'm going to be told I have to get to a certain minimum weight. I have to control my diabetes. I better be careful about infection and hygiene. And many other factors. They will not operate on me. Now, admittedly, I'm not going to die, but I could be in a lot of miserable pain and extremely poor quality of life because they're not going to take me until I get to achieve some of these pre-surgical eligibility requirements. Are they being punitive because they don't like obese people or they don't want people who risk falls because they're drinking? No, they're watching outcome. As Brendan said, it's the duty of the programs, not just to set the standards, but to supply the programs to counsel people, enable people to get to these desirable pre-surgical conditions. So it isn't totally unique to transplant that we'd start to say for good outcome, these are the things you want to do. I think what we have to do better for vaccination and other things is institute the educational program, teach people how to talk to the hesitant so that we can swing them around.
Well, thank you both. This has been a really enlightening discussion, both in the JCF Ignite piece and here with us today on our YouTube channel. So thank you for being here. I want to pass it back to Anu just for some closing comments.
Quentin, thank you so much. You did such a wonderful job moderating this exciting discussion. We're so fortunate, Art and Brendan, that you were able to join us today for another episode of our JCF YouTube channel. We are very excited about continuing this constructive discourse with our community and our readers, and we recognize that information is received in many different ways. So we encourage you all to stay in touch, and we are grateful for your viewership and support. Until next time.